So we're ready for the second session. Welcome, everybody. This session is entitled Biliary Disorders. My name's Todd Barron, and I am the moderator along with Anna Deloy, and she will be introducing the speakers.
Great. Welcome back, everyone. Our first speaker is Dr. Paul Leonor. He's going to be talking about optimizing success to remove large biliary stones. He's an assistant professor at Loma Linda. He's an exceptional clinician, endoscopist. He was one of our greatest fellows, and we miss him, and we're very happy to have him back.
Hello. Can everyone hear me?
Yes.
All right. So just like a lot of the panel had iterated before, just a couple of years ago, I was one of the audience members here attending this course, and I'm honored and humbled to have been invited back here. I miss the people that I trained with here, amazing faculty, mentors, lifelong friends, and especially some of the nurses as well. So it's nice to be back here. Today, I'm tasked with talking about optimizing success in removing large bile duct stones. And this is a picture of our beautiful med school campus with our new hospital here in the background out in sunny Southern California. So if anyone's out there, please feel free to drop by. I have no disclosures. So just a little introduction. The majority of bile duct stones can be removed by standard biliary techniques, mainly biliary sphincterotomy and balloon sweeps. However, upwards of 10 to 15% of bile duct stones can be classified as difficult, complicated stones. And what that entails are various characteristics that have to do with the stones themselves, such as having multiple stones, having, what's going on? Having larger stones defined as greater than 1 centimeter, which is will be the main focus of this talk today, or stones that are in difficult locations, such as stones that are proximal to strictures, that are intrahepatic, or as in Dr. Arnell's case yesterday, they may be intrahepatic and above a stricture, so those are particularly difficult. And certain anatomic factors, such as surgically altered anatomy, the main ones that come to mind are patients with Roux-en-Y gastric bypass, which will not really be part of the focus of this talk, but particularly for large stones in surgically altered anatomy, a lot of the devices that we have are not able to be used with a double balloon or balloon-assisted ERCP. So at that point, you start thinking about alternative maneuvers such as laparoscopy-assisted ERCP versus EDGE or transgastric or EOS-directed transgastric ERCP. But to remove large stones, a lot of the concepts have been kind of touched upon in dealing with difficult pancreatic duct stones as well. But the two main strategies are, first of all, improving the outflow, so opening up a pathway for these large stones to be removed. And that usually consists of a combination of endoscopic sphincterotomy and large papillary balloon dilation. And the other strategy is to make the stones smaller to make them more easily extracted. And that entails lithotripsy, which can either be mechanical versus cholangioscopy guided lithotripsy, which is then divided into electrohydraulic, EHL, or laser lithotripsy, both of which we've kind of touched upon already when talking about pancreatic duct stones. But large papillary balloon dilation is mainly defined as dilating the papillary orifice with a large balloon, typically 12 to 20 millimeters in diameter. So not every duct can be dilated to 20 millimeters. You're typically limited by the maximal diameter of the lower bile duct. So we talked about this yesterday. You know, even though the common hepatic duct may be markedly dilated, if down below it's only about 12 to 15 millimeters, that's probably the maximal that you would dilate to avoid complications such as a bile duct perforation. And typically, once it's inflated, you would hold it for about 30 to 60 seconds, ideally after the disappearance of the waste seen fluoroscopically. Theoretically, you can do this with or without a biliary sphincterotomy, but for the most part, people are doing at least a limited sphincterotomy followed by the large papillary balloon dilation. Theoretically, without a sphincterotomy, you may increase the risk of post-ESP pancreatitis because you are exerting more pressure on the pancreatic duct orifice. But data is extremely limited in just doing large papillary balloon dilation alone, but the risks appear to be similar. So this is just an example of multiple large bile duct stones here, and fluoroscopically you can see the balloon dilator here with the waste. And again, ideally you would hold that up to 30 to 60 seconds. Once that waste disappears, so this is kind of what it looks like endoscopically, and then you're able to extract the stones once that outlet is improved. So comparing sphincterotomy with large papillary balloon dilation versus sphincterotomy alone, the overall success is pretty similar, about 96.5% to versus 95.3%. And sort of what I touched upon earlier, lower pancreatitis risk when these are combined versus just sphincterotomy alone. And then again, there's not much data on just doing large papillary balloon dilation by itself. Most of it has been in combination with at least a limited sphincterotomy. But again, the overall success seems to be pretty similar and is upwards of 97%. And in older randomized control trials, it appears that doing the combination of large papillary balloon dilation with sphincterotomy may reduce the need to perform mechanical lithotripsy. So what is mechanical lithotripsy? It involves using a wire basket to grasp the stone and a handle to withdraw the sheath or the basket into a sheath, which results in a crushing force to break up the stone within the basket, making the stone smaller and easier to extract. So these are just a couple of examples of the devices used to crush the stones. And this also has very good success rates. So it leads to complete bile duct clearance in about 80 to 90% of cases, but up to 20 to 30% may require multiple sessions. It's less likely to be successful for particularly large stones, especially once it gets upwards of 25 millimeters or greater, or if the stones are very impacted. And this is because your ability to open the basket and grasp the stone is limited. So in this particular case series, with the median stone diameter of 18 millimeters, the success rate dropped pretty significantly for stones greater than 25 millimeters compared to less than 25 millimeters. And that success rate dropped from about 87.6% all the way down to 67.6%. And the risks of doing a mechanical lithotripsy are similar to any other ERCP, namely bleeding, infection, perforation, cholangitis, and pancreatitis. But I think the most feared adverse event is entrapment of the basket. So you're not able to remove or extract the basket with the stones across the bile duct. But this seems to be, the incidence of this is a lot lower than we probably need to worry about. In this retrospective cohort, there were 643 cases. 29% of them had lithotripsy-related adverse events, namely trapped or broken baskets, fracture of the wire, broken handles, perforation of the bile duct. And almost all of these were able to be salvaged endoscopically, and only one of them ended up needing surgery. So by doing alternative techniques, using the emergency lithotripter or even extending the sphincterotomy, are these cases able to be salvaged. And then moving on from mechanical to cholangioscopy-guided lithotripsy, we've had several cases of this already during this conference. It's mainly a single operator cholangioscopy with a scope within the duodenoscope. And first modality is electrohydraulic lithotripsy, which uses a bipolar probe with a charge generator, and it transmits a charge across electrodes to produce a spark. And this is sort of an animation of that. It causes expansion of the surrounding fluid and an oscillating shock wave of pressure that leads to fragmentation of the stone. And ideally, you'd want a little bit of space, about 1 to 2 millimeters from the tip of the probe to the stone to allow propagation of that wave to impact the stone. So this is a case that I did. Yeah, this large bile duct stone here. This is partially just a large duodenal diverticulum. At first I thought it was 2 stones, but ended up only being 1. So via cholangioscopy, you see this large stone here. Once started going to work at it with EHL, get this sort of asteroid field appearance, a lot of broken fragments, and then eventually we're able to sweep out these fragments and clear the duct. And then that's contrasted with laser lithotripsy, which focuses a laser light of high power density to the surface of the stone. It creates a plasma of a gaseous collection of ions and free electrons that similarly oscillates and produces a pressure wave to fracture the stone. And the main laser that we use for this that's commercially available is a holmium laser, which is what we saw during the cases yesterday for at least the lithotripsy portions. And it's very precise or relatively compared to EHL, which may reduce the risk of damage to the surrounding bile duct. So the overall success rate of EHL or laser lithotripsy is very high, exceeds upwards of 90%. In this randomized controlled trial of 60 patients with stones greater than 10 millimeters that were randomized to either cholangioscopy-guided laser lithotripsy versus conventional techniques, which include, balloon and basket extraction, large papillary balloon dilation, or mechanical lithotripsy. The success was fairly higher in the cholangioscopy-guided laser lithotripsy compared to conventional techniques. There hasn't really been much prospective head-to-head trials comparing EHL versus laser, but at least in retrospective data, it appears to be pretty similar between the two. And the choice between the two is probably more dictated by what's available locally. At least at my institution, we don't have the laser readily available. I think even here, we end up having to rent the laser from the laser company. So I guess we'll hold the questions for the Q&A session, but it's just a picture of my family as we were leaving Colorado after my advanced fellowship. So I hope with this, I felt very comfortable leaving Colorado. I felt well prepared. So I hope you guys are feeling well prepared to tackle on large bile duct stones.